So, good evening and welcome to tonight's primary care seminar hosted by the Primary Care Education Department at City St George's, University of London. My name's Lucy Williams. I'm a GP and a clinical lecturer at City St George's. So tonight is the first of this year's primary care seminar series, which is in its third year now, aiming to showcase the diverse opportunities available within a career in primary care to both students and professionals alike. The seminars have been co-created with our students, so medical students and students from other allied healthcare courses have been the driving force behind these events. And it is through their input and passion that we are able to explore a variety of topics within the field, highlighting the vast potential that a career in academic primary care can offer. So tonight's topic, chosen by our students, focuses on an important and often under-discussed issue in primary care, public health and medical education perspectives on gambling harms. Our students highlighted this as an important area where healthcare professionals, particularly in primary care, are uniquely positioned to play a key role in identifying and supporting those affected. To help us navigate this, we are delighted to welcome tonight's speaker, Dr Jenny Blythe, who is a North East London GP and a senior clinical lecturer at Barts and the London Medical School, Queen Mary, University of London. She holds a master's and a PhD in public health, and her thesis was titled Gambling with the Health of Londoners, Levers and Barriers to Addressing Gambling Harms Using Public Health Approaches in Local Government. Her research interests include developing the health equity and generalism undergraduate medical curriculum. So Dr Blythe will be speaking for the next 40 minutes or so, and then we'll have a Q&A. So please use the Q&A box to submit any comments and questions. So without further ado, I'm going to hand over now to Dr Jenny Blythe.
Thank you very much, and thank you for the invitation to speak, and hello to a few familiar names in the audience I can see here, and I might just call on some of you later. So I'm just going to start sharing my screen. Okay, confirming everybody can see that?
Yep.
Okay, excellent. So yeah, thank you for inviting me to speak tonight, and the first of your series for this year on gambling harms. This presentation is actually adapted from a presentation I gave at the Society of Academic Primary Care in January of this year, when there were some people from City St George's there and got speaking to them, and some students and public health academics, and this is how we got in touch, and I was invited this evening. So yep, I wear various hats in my daily life. So I am a GP in North East London. I have been for the last 20 years. Just got back from my clinic today in Walthamstow. I'm a senior clinical lecturer at Barts and the London Medical School, which is now part of Queen Mary, University of London. And I started there as a clinical lecturer over a decade ago, and then became a senior clinical lecturer a few years later. And in terms of my PhD, I'll explain a little bit more about it, but I was a doctoral fellow based at the School of Hygiene. So before we start, always really important when you talk about gambling to talk about a few things up front. So first of all, gambling harms are really widespread and they're often hidden, and we'll talk a little bit about why that is the case. And if you need to sort of step out, please do so. There's resources at the end of the slide pack if you feel that you need them. I am easily findable at QMUL and always happy to talk on record, off record about sort of, you know, with if anybody needs any sort of guidance or signposting. It's also really important to talk about funding in terms of gambling research, and we'll talk a little bit about that as well. So I was in a very unusual position that I was fully funded by the NIHR. Only one other person so far had that, and it was an arrangement where the NIHR funds the PhD, but then you are hosted by one of the organisations. So I was hosted by the School of Hygiene, the London School of Hygiene and Tropical Medicine, and then you are looked after by the academic area. So they've got different names in different parts of the country, but mine was the North Thames ARC. And then finally, another particular thing we'll talk about gambling research is it's constantly a moving field. When I gave this talk in SAPSI, the Society of Academic Primary Care, in January, it was out of date date in the 24 hours after I wrote it. And I wrote this on Thursday before I took a long weekend for my birthday, and it was out of date again before yesterday. So I'll explain why that happens, and it's sort of part of the nature of gambling research, and I'll point out what's sort of come out, because it's actually really important for primary care and medical education what's happened in the next few days. So those are sort of the starting points here. What we're going to talk about. So I understand that you're, from talking to Lucy, you're a mixed bunch. So I was going to give you an overview of my career pathway, sort of how I've balanced GP, medical education, and the PhD, and then talk about gambling harms from various different lenses. I'm not going to speak for the 40 minutes. I'm more than happy to have the conversations about it. And like I said, I've spotted a few familiar names in the team already who've joined, so I might pick on them to sort of put in a bit too. Talk about gambling harms in primary care, talk about gambling harms in public health. That was sort of the research lens that I used, and then how I am taking those two experiences and moving that into medical education now. So gambling harms in medical education. And you'll notice that a lot of these photos were actually taken while they're local photos from where I live and work in Northeast London. So this is my local newsagent in Leighton in E10, one of the poorest boroughs in Northeast London. And a lot of these photos are sort of taken from the area when I was where I live and where I work, and where I also sort of send medical students as well. So a brief overview of the career pathway. I qualified as a doctor from Dundee in 2003, did individual jobs until 2008 when I qualified as a GP. You used to be able to do sort of standalone jobs until you felt ready to go and do your GP year. So I did that. And in that time, moved from Scotland down to London. I started a master's in public health soon after I qualified as a GP, and I selected one that was online, part-time, over the maximum time of 5 years, and actually you had to do 8 modules in a dissertation, and I did a module per semester for 4 years while my children were little. And then in my first year at working at QMUL, I did my dissertation over that time. So when I was a GP in practice, I always worked part-time as a GP in practice alongside all the other things going on. I was a GP tutor, and there was an opportunity that came up to a maternity cover for the module lead for the module that I was teaching in practice, and I took that on, and then was made permanent when another one of the module leads resigned. And I did that up until from 2014 till 2020. And by then I was a senior clinical lecturer, and I was beginning to think I probably needed to do a PhD to get to that next level in academia. There are certain jobs which you don't, that you don't make. That is one of the cutoffs, that you need to get a PhD. So I'd started looking, and then and I was looking at both medical education and public health PhDs, recognizing that I had the PG certificate in medical education, but the master's in public health. And then the PhD in gambling harms came up. What I haven't mentioned on here is that I used to attend an organization called Gamanon, as you're not quite a volunteer, but as I used to attend because a friend of my husband's had a significant a gambling issue at one point, and I was basically the person with the car. So I used to take him to a local Gamblers Anonymous, and it was one of the very few in London that had a Gamanon attached to it. And Gamanon is the kind of sister organization to Gamblers Anonymous, and it supports families and friends of people who are struggling with gambling harms. So my choice was, did I sit in the car freezing for 2 hours while my friend was in there, or did I go inside? And I met some incredible people, parents and spouses, friends that were supporting loved ones that were struggling with gambling harms. And so when this particular PhD was advertised, I felt that I could give something uniquely from that perspective, that I had some public health background, I had some primary care background, but I also had this kind of, I wouldn't class myself as an affected other compared to the people that I met, but I did have that sort of different lens about looking into it. And at that point, I stepped away from Gam-Anon because I didn't feel that it was fair on the people that were going, that even if they might think that I was using them as an example, for example, and I wasn't, but I didn't want to kind of cloud that. So that was a point I stepped away from Gam-Anon. I started the PhD in September of 2020 at the School of Hygiene, which is one of the global places to do public health. Unexpectedly, it ended up being working from home. I was looking forward to being in the new School of Hygiene buildings, but they were closed for the first year or 2 years of my PhD. And I was also interested in looking at land-based gambling specifically, and a lot of that was closed too. But it didn't mean that it still wasn't being licensed and places were getting approvals for opening. And so my actual PhD was not what I expected it to be. It was primarily working from home. It was primarily online, when I'd always said I wanted to be in that sort of learning environment in person. But it was of its time, and there are lots of different conversations that you can have about sort of what PhDs look like over the pandemic period, and sort of benefits and disadvantages. And then I finished my PhD in 2024, and I went back to QMUL. And so I do that now part-time alongside my job as a GP, where I'm currently interim head of year 3. So that's sort of an overview of the career academic pathway. I'm more than happy to answer sort of any questions about any of that as I go along. The other thing that I should mention here is that while I was doing the PhD, I was also one of the 2 GP representatives on the NICE guideline for gambling harms, which was very delayed coming out. In fact, it was, by the time it was recruited, written, and all the delays that came onto it came in terms of publication, my PhD was nearly over. But they also meant that as a GP, I was watching how a NICE guideline is created, and that's also very interesting in terms of that process. Now I understand why the statements are how they are, and again, more than happy to sort of talk about that. So I was on as one of the 2 GP representatives. There was somebody there from academia, but actually they were from a very narrow area of academia in terms of very specialist care, psychiatry, exploratory medication, so the very narrow side of it. And so even though I wasn't there as the formal academia representative on the NICE guideline, I could sort of put things into that as well. But in terms of how a NICE guideline is put together, that's also, if you ever get the opportunity when they send sort of call outs to be the GP representatives on it, I would thoroughly recommend it. It is it's a really valuable experience in terms of what you learn about how the guidelines are put together and the different pushes and pulls. Okay, so a bit of an overview about gambling harms before we go and look at this sort of individual lenses. This is the sort of traditional model of how, from Langham from 2015, how we think about different ways that gambling harms can affect individuals over time, and at different times in their lives as well. So it's not just financial harm. At the end of the day, there is an impact on mental health. There is a real sort of emphasis on something called co-occurrence, so things like substance misuse, alcohol. People that are experiencing gambling harms directly have higher rates of divorce. People that the implications of financial issues can lead to job loss and homelessness. We don't talk about it enough, but gambling harms can lead to suicide, and there are people on the call tonight here from Gambling with Lives, and I will probably bring them in later on. I learned a wealth of knowledge from Gambling with Lives as the charity when I was doing my PhD, and haven't managed to catch up with them, so I'm really happy to see them here tonight. And we don't just think about individuals that are harmed by gambling. Depending on the research that you look at, you're talking about 7 to 10 people directly affected by one person's gambling. So the phrase that we use at the moment is affected others, spouses, parents, children, work, society. So in terms of the broader look, but friends and family are your affected others. High rates of domestic violence, relationship breakdown, impacts of finance, adverse childhood experiences. So if we start beginning to think about that kind of conceptualization of gambling harms, not just being the individual, suddenly the numbers get a lot bigger, and we talk a little bit about how data is collected about the stats, but sort of somewhere between 7 to 10% of the UK population. If you take an all harms lens for gambling harms, then you're looking at 7 to 10% of the population. It is not small, and it is hidden. And then we're thinking about direct and indirect crime related to gambling harms, and then work productivity loss, so job loss if you lose your job in terms of sort of your prioritizing of gambling at its worst. So why is it hidden? Why did it's interesting a bit in terms of for the students, in terms of recognizing that they want to talk about it. Words really matter, and there's lots of shame and stigma around gambling harms. People talking about money, people wanting to, people admitting that either themselves or that those close to them are struggling. The language has been stigmatizing by nature, and we talk about problem gamblers, and this is a very old-fashioned, narrow, stigmatizing name. And you'll notice that, for example, in the NICE guideline, we talked about gambling harms. If you see problem gambler, or you hear that in the narrative in government, it's really putting the problem with the person rather than the problem with the product and the problem with the gamblification of society, and talking about that. And there's also something about vulnerable groups. Now, is it that you could argue that anybody is vulnerable if you've got highly addictive products that are very hard to get your extricate yourself from, and if you follow some of the gambling podcasts, people tell you about how being chased by when they do try and sort of disengage, lots of emails, being reminded of free bets on days of payday, things like that. Are these people the really vulnerable groups, or are we talking about a predatory industry tactics to try and get people back to engage? And also, historically, the people who have researched gambling often came out of fields like looking at substance misuse. And this is not aligning to substance misuse. This is a normalized, socially acceptable, conceptualized as leisure activity. So if you're going to align it to anything, align it to something like alcohol that is socially normalized, acceptable, legal, but then as somebody pointed out to me, nobody knocks on your door at 1 o'clock in the morning is offering you free shots, okay? But they can be in terms of sort of for online gambling. So gambling has been completely normalized. Even in the pandemic, when we were talking, it was all still people putting bets on the horses in Ireland, for example. Even sort of, I remember having conversations with my neighbour over the fence, sort of, and that normalization from childhood as well. So Steve Sherman does lots of research about this, sort of people that can feel extra shame and stigma if they remember something positive from their childhood, from a different kind of gambling experience. For example, being felt grown up to go and put the name on being asked to choose the name for the horse on the Grand National, or go and put a bet on once a year. Or in northeast London, we have a dog track, and again, I have lots of conversations with patients now about gambling, because they know that I do this kind of work, and those sort of romanticized memories of experiences around gambling can, if it becomes harmful for you, it can make it more shameful and stigmatizing. We've already talked a little bit here about the predatory tactics of the industry. you can talk about this for the whole hour, but like I said, those examples that I'm giving you about people trying to disengage and then getting bombarded with emails, people getting specifically bombarded on payday with free bets, those are all strategies that happen. And, you know, we do not talk about that enough. We don't talk about that enough. We put the onus on the individual to take themselves out of the picture. These are products that are what's called addicted by design, and you know, the rapid, constant, modern online gambling, you know, and the machines that where the stakes have recently come down, you know, even more so. So the problem is not with the person; it is to do with the products and the predatory industry. There's also something about harms being experienced inequitably. So there's if you live somewhere that's in lower deprivation, and this is what I studied in London, there is more physical places to gamble numerically, and that is getting worse. So one of the things that I did in my PhD is that I looked at gambling premises, so all gambling premises, not just betting shops, but arcades, casinos, and bingo halls. And what I looked at is when I ranked boroughs by deprivation, what was this sort of access, numerical access to gambling premises. And it's a correlation, and it's getting worse, and it's getting worse every 6 months. So please don't feel sorry for Betfred when they're telling you that the slight increase at the moment is going to you really have a negative effect on them. This is something a little bit different in terms of the numbers that they're using, which was quite interesting, which again we can talk about later. This photo is from relatively near my house, actually. The sort of the Betfred Petty Power near to one another. So yeah, if you are in an area where you are less likely as a population to shout up for yourself, then there's going to be more of these kind of places that that are easily accessible for you. Betting shops typically they have licenses where they only have 4 machines per block, but you can always buy a double block. Like this could be one shop, for example, and then you can have 8 machines in there. And you don't have the same kind of rules in machines in adult gaming centres, so these adult arcades. You don't have them in bingo. You can have all sorts of machines, and it's all to do with floor space. It's not to do with numerical. So what we're seeing actually across London is a concentration of land-based gambling into areas of deprivation, and actually betting shops, they're not even going down. Don't believe that. They're not going down actually numerically in London, but they're concentrating into areas of deprivation, and more arcades are building up all over the place. So more bingo, more arcades, and those don't have the kind of cap numbers of machines. And then also from a policy point of view, gambling falls under the Department of Culture, Media and Sport. Unlike alcohol falls under the Department of Health. And that means what drives that the narrative in policy is different. Okay, so there was a House of Lords review in 2020, and there was a discussion about whether gambling should be moved over to the Department of Health, but it was felt not. It was felt that they could tap in if they wanted to, but it was fine where it was. I personally think this was a missed opportunity. If I was going to align this to anything, I would be aligning it to alcohol. Alcohol falls under the Department of Health. I don't understand why that decision was made, but it was made at the time. But that means that the people that are involved and the framing of problems are around leisure. Gambling is still primarily classed as leisure, as a minority of people that have a problem with it, and that is because and that's where that the narrative then comes from in terms of individuals having problems. This is not a neutral leisure activity. You don't need to warn people to go to the cinema or the theatre more safely, but that is part of what's going on in terms of the gambling advertising at the moment. And we need to talk about this. It's Champions League in an hour. we've got even more, and for the World Cup as well, we've got even more teams that are involved every year now. Primarily football, but other sports are coming in as well. Mostly male sports at the moment, and there was massive pushback in Australia when it was the cricket actually that nearly got gambling advertising, but there was a really good pushback. Australia are quite a long way ahead of us to work out sort of how harmful gambling can be. One of the things that again, unexpected of the PhD was that because I was at home, I had the TV on all day with the sound down, and I watched during the day how bingo is advertised, and bingo is advertised very heavily in the day to a different kind of clientele. And in fact, there was one particular bingo company that got in trouble for directly marketing to new mums, and basically saying this was a way of sort of meeting people online in the pandemic. They were trying to sort of promote it, but thankfully that did get sort of quashed. But bingo during the day, lots of advertising for it. Most of the big I think I'm a Celebrity tends to do a bingo one as well. So again, that normalizing in society. And there isn't this kind of, there's a kind of grey area where gaming and things like skins, for example, can move into gambling products. One of the decisions that was made at the beginning of the NICE guideline was that we were going to only talk about gambling, and we were going to only talk about 18 and over. Again, I feel that was a missed opportunity, because there is this grey interface, and there are lots of things that, I have 2 teenagers, and there are lots of things in terms of their gaming that you see and you think, that chance and those loot boxes and things like that, they are the segue. They're the segue in, and even sort of things like Candy Crush and those kinds of things have opportunities where there's chance, where you can pay more money to get something of chance, and that is gambling. Okay, we've already talked about how gambling is conceptualized as a leisure activity in national government, and it's also an income stream. Massive amounts of tax sort of paid in nationally, and also locally. So in local government, big companies can be seen as good rent in high streets that are struggling, and so you need sort of strategies for healthy high streets, which is where public health can come in. And then again, there's also this concept of gambling for good. So, lotteries and tombolas, you're encouraged to put money towards them, the national lottery and the postcode lotteries, for example, or tombolas at local sort of festivals or parties, raising money. But at the end of the day, that is still gambling, and actually can still be quite triggering for sort of individuals. So it's recognizing that as well, much more widespread than when you start thinking about putting money down for chance. Right, so first of our lenses, seeing gambling harms in primary care. It's going to be relatively unusual at the moment for somebody to come in and say to you that they're experiencing gambling harms directly or indirectly, but there are other ways that it might come up. Okay, so often you're seeing those sort of things that we've been talking about, the mental health issues, we've talked about suicide as well. We'll talk about that sort of specifically later on as well. People experiencing depression, anxiety, or alcohol substance misuse, there is a common co-occurrence, and there might be something going on there, and that's certainly supported by interviews that I did with sort of, well, I would call them CGL in North East London, but yes, often that comes out when patients are referred to those kinds of services, and there'll be some gambling going on as well. We can see it in terms of financial neglect in our children, or that are coming into primary care, or people expressing financial difficulty. Now, how do you unpick that? We're in a cost of living crisis, and we live in London. Everything's like completely expensive. But there's a link at the end to an article that I wrote for BMJ about sort of segues in, and I started the NICE guideline really wanting to be asking about this as a screening question in primary care, normalizing it. So kind of like the e-consult did at the beginning when it first came out. Do you smoke? Do you drink? Do you gamble? Interestingly, the e-consult moved relatively quickly to it being a question that you could kind of skip over if you didn't want to. I never kind of got to the bottom of why. And actually at that time I was working with Hurley Group, who founded the eConsult, and they also, the people that did the changes, weren't quite sure why it had gone to that, why we'd stopped capturing that sort of data. The more we normalize asking, as part of, the better it is. Now, in terms of the screening, the reason that we suggested asking the question in GP, but there are very sort of, there's national screening programs and criteria for actual screening, and it didn't meet those kind of public health pure criteria at the moment. But we did, in the NICE guideline, talk about questions that you could ask, opportunities that you could ask. Also I talk about this in the BMJ article as well. So if somebody is expressing they're having issues with finance, normalizing the asking of sometimes this is happening because somebody has gambled more than they need to, they can afford, or they're living with somebody that can. It's now something that I've really worked with our local social prescribers in North East London and got them to sort of ask it, and then signpost on to the right people. Because if you're going to ask it, and if somebody is struggling, your next question, when we talk, and we'll talk about this in the next slide about managing it, is to understand at that moment in time, is that person at risk at suicide? Because we're talking about one person a day committing suicide in the UK alone because of their gambling harms, and that has been going on for years, and that continues to go on. So while we are still in this grey area of where does GP's responsibility for it to lie, we need to sort of understand that if you are, I wonder if people don't ask the question because they don't know what to do with the information. That's one of the things. And interestingly, in EMIS at the moment, we still only have one code, and it is problem gambler. And that is also an issue. I mean, how long did it take to get a code for COVID, for example? Now we've still got these three, and that was a really fast track through. We're not going to get a code. It's going to be like long COVID, where there's going to be people experience like coded with all these other things. We're not going to capture that data. So, there is something around the asking and then the signposting. And we've already talked about here about 1 in 7 to 1 in 10 of the UK population experiencing gambling harms, if we're talking about that all harms lens, and 20% of affected others are experiencing harms to the same degree as the person who gambles. So, this is, serious stuff. So there's something about, in GP about normalizing the asking. There's something about offering resources that are independent of industry-friendly narrative. So that is along the lines of saying to people, this is not your fault. The products are addictive. The industry is predatory, and that you're offering them that non-judgmental support and not putting all of the weight on the individual that has come to you to solve the problem. Now, the RCGP training, they did come out last year. Again, I wrote something for the BMJ with this. They did write it with Gamble Aware, and I haven't seen it since, but I know that that's sort of where it was going at that moment. You want to be prioritizing, you want to be giving equal weight to the non-industry friendly narrative. So the non-industry friendly narrative is actually the public health narrative, and the public health narrative is that it is not the individual's fault. Okay, so I do not hear, we've got some people on the call, or I could see from Gambling with Lives, and they have created with Manchester Council something, some non-industry, some resources that are independent of that focus on that sort of framing of it. This is not your fault. This is a multinational, multi-billion organization, and need to be seen as non-judgmental, and watching language and the assumptions. And super important, if somebody has come to you and they are struggling, that you ask them about suicide. It's really, really important, because if they're sort of hit rock bottom, and that you're meeting them at some of the most desperate times, because a lot of money can be lost very fast, and it can all feel completely hopeless. So the second lens is from public health. Okay, and public health would talk about primary prevention. You may have heard about the levy. So the levy was with the white paper in the new Gambling Act, and this was the whole idea that gambling industry would be mandated to give some kind of money to the system in terms of prevention, research, and treatment. They're still arguing about how much and should certain products have more, and all the public health groups could have sort of said, well, you know, we could have told you this was coming, this will go on for a long time, and it will prevent, and every day that it goes on, another person dies and more people get harmed and lose all their money. Okay, so delay is a technique, as is kind of the sort of creating research that is sort of very narrow or asking questions that are industry friendly. And if you look at the kind of the cut here, this isn't a prevention levy here. We're waiting for people to get harmed and then we'll do the treatment. So prevention at the moment is only 30%. And when we think about primary prevention in public health, we look to WHO, so the World Health Organization, and there are three kind of ideas that they talk about. They talk about reducing availability of a harmful product, reducing advertising of a harmful product, and increasing price of a harmful product. Now, price is a little bit of a sticky one with gambling harms because often your losses are hidden. You don't realize how much you're losing because you get these kind of mini wins in between, but overall you're losing. So from a public health perspective, places like Australia, New Zealand, they have reduced availability and reduced advertising, so that those are the kind of things when we talk about primary prevention. Okay, and then stricter policies on products in terms of spins and like online spins, for example, and financially meaningful fines on industry. So if a multi-billion industry is going to get a slap on the wrist of a few thousand or 10,000 or or whatever, they can factor that into their profits. Okay, so meaningful fines on industry. Research. So at the moment, a lot of the research goes into medicine, so medicines of medicines that aren't licensed and sort of all of that, and that's that nexus between pharmaceuticals and we think about that as well. I don't think that 20% is enough here, that if you really want to prevent gambling harms, that you've got to sort of put in research that's looking at true preventative strategies. But the downside of that is there's going to be less profits, and less profits mean that the industry can say to the government, well, it's not going to be as much tax for you. And so that's why then they come and focus on things like treatments. Now, treatments are very narrow. They're for the sort of the specific sort of definitions, DSM definitions of problem gambling, for example. They're sort of done in very sort of specialist highbrow areas. And look, they've got the majority of the levy here. So it's really upside down. I'm not saying that individual voluntary tactics such as self-exclusion, sort of in-person online, they're not entirely bad, but they are not the sort of the mainstay of treatment for individuals if you really want to prevent gambling harms and stop them sort of continuing. But the consequence of that is that the profits will go down, and this company and this organization and industry is going to fight that, especially as they've got that sort of hand in government as well, and sort of giving lots of politicians free tickets to everything, so in terms of like cups and things like that. So it's a very the nexus is really murky in terms of that. So these are the kind of public health lenses that we talk about with it. And this is the bit that got updated during my long weekend. Okay, so I wrote a second article for the BMJ, and that was about how we teach gambling harms at medical school. And my argument is that there are various different lenses that we can use. Using pure psychiatry addiction frameworks might not be helpful, and there's an opportunity here to think about gambling harms in the broader sense. So in primary care, do we do things like role play, or do we ask about it in terms of financial when we've got social prescribers? Pediatrics, what do we see in terms of neglect? Psychiatry might be part of it, but it's only sort of part of it, and there's an opportunity at medical school and in medical education to think about gambling harms more widely, and not in that sort of stigmatizing way of problem gambling narrative. We've already talked about public health. So public health is also a big part of underpinning a lot of what we do in medical school, social and population health, although it doesn't have its own area in the new medical licensing assessment, which is another one of my bugbears, but that's for another day. But talking about prevention, real true primary prevention, population health, what does that look like? Advertising, social determinants of health, inequality. So what it means for our patients that are living in deprivation, and and what they're exposed to. And using sort of more of disposable income on that small chance that when you've got no hope that you might win something. So these conversations have actually been around in public health for 100 years. We talk about that sort of that hope, and that it's when you've got nothing sort of to lose, and in that way, so that desperateness. And then there's ethics as well. What do we think about what do we think about the gambling industry being able to do this? What do we think about the government taking tax revenue from industries, for example? What do we think about industry being involved in charities that then go into communities and medical schools, and actually schools? So actually we've got we've got a national young person's gambling charity that helps write the PHSE curriculum. What do we think about that? And the bit where this went out of date is the new MLA content when Matt went out. So I'm assuming you all know what the MLA is. This is going to go live in 2026, and gambling disorder has been listed as a patient condition. This is a really big step forward. I'm so happy about this. I'm also happy that it's moved away from, in the draft that I saw, it was called gambling problem. So I did say, really don't like that. Could we move to gambling harms, or maybe gambling disorder? I got halfway there. I've got it in, feeling really happy about this, because that means that we can start really thinking about how we're going to teach it at medical school. But there's also a risk here. So just as I'm happy, there are also several charities that are ready to go, and they are contacting PsychSoc, they are contacting medical schools, and they're saying, I've got a package that I'm more than free to come and deliver to you. Let me come and deliver that. They've done it all across local government in the UK at the moment, and this is a new area for them to move into. I'll come to your Freshers Week. I'll come to your PsychSoc. You don't have to do anything. Don't worry about it. And the first question that all of you have to ask is that, of anybody that does that, is who's funding this and what is the narrative? And if the narrative is all about you as an individual, signing up to self-exclude, and really minimizes talk about things like suicide and talk about things like policy, then you probably need to ask some questions about who's funding it. Okay, it's really hidden in plain sight, those kinds of narratives. So be aware of that as well. And also there's something about gambling harms in students as well. So I'm in East London, and certainly this year I saw some both bingo and casino flyers for students new to North East London, which is delightful. I saw an industry funded charity at another higher educational institution's Freshers Week. Like I said, it's not unheard of, sort of approaching societies like PsychSoc and offering a talk and things like that. When you are first away from home, it can be really easy to lose control of finances. You're managing your own money. If you're a medical student, you could be on placements. You could be quite isolated. Everybody's online all of the time. Casinos in pockets, in terms of is the phrase for mobile phones. So it's really easy to get sucked in. If you were a medical student, again, there can be reduced chances to earn money, and I have lots of conversations with students around money at the moment as head of year 3. So again, these can be sort of, you can think that this is an opportunity as a quick win, or these kind of losses disguised as wins. And there is that additional stigma around medical students disclosing something like this. They are going to worry about what the disclosures mean. And I work really closely with student support, both at QMUL and wider in London, to signpost goes towards to support them in the asking and then the signposting, but really encourage to anybody that is struggling directly or indirectly, you might be living with somebody as well who's struggling with gambling harms, that you seek some support. Don't keep it to yourself. It's not their fault. It's the products, it's the industry, and go and seek support. And a list of a few things here to speak about. I'm always going to lobby for Gamblers Anonymous. They are not in the dialogue, but that's because they are anonymous. If anybody is struggling, you can go onto the national website. You can find there is a Gamblers Anonymous pretty much everywhere, every night, every town. Gam-Anon are a bit further and fewer between, but they are around as well. Chapter 1, I'll pull Liz James in a minute and find out where you are with chapter 1, but this is where the Gambling with Lies were working with Manchester, so those industry, those non-industry resources. For anybody struggling with thoughts of suicide or involved with anybody who's thinking about, has expressed feelings, there is always the Samaritans as well. And the final two I asterisk because they do have industry funding, but they are there. So we've got the National Gambling Helpline, which is open, and we've got the Primary Care Gambling Service, which is based at the Hurley Group in South London. But again, I've put them with the asterisks just to sort of make you aware that, that they are they have had some industry funding. So that is a whistle-stop tour. I'll leave that up for a second because that's got some of the references here. So the ones to tell you about, you can see here I've still got NICE as the TBC in terms of it came out in January of this year, the Gambling Act of 2005, and then the white paper that came out in 2023. And then there's the teaching about gambling harms with the DOI there. If anybody emails me, I can send a link to my thesis if anyone's particularly interested in any of it specifically. But yeah, so happy to take questions from any of those lenses. Thank you.
Thank you so much, Jenny. That was so insightful and just a really amazing overview into how prevalent gambling harm. I don't think I really realised as a clinician how much this can impact both, individuals, but as you said, those affected others and things like that as well. So certainly a lot to take forward into clinical practice. We're just waiting for some questions to come in. I'm hoping everything is okay with our chat, but please do have a go. We can publish them, but maybe I'll start off if that's okay. I guess with the change, if I'm very tempted to go straight to public health, but I'll keep my medical education hat on. Just thinking about the MLA content map that you've highlighted has just changed to include gambling disorders. I guess from a medical student perspective, you've talked about, it's just normalizing and some of those vocabulary and things like that we can do, but is there any sort of key tips or competencies that you would say are really important for medical students to sort of take forward into their practice, particularly, those in the clinical years and whatnot?
So I think that there's something about if there's normalizing the asking, first of all. If somebody had along the lines of do you drink, do you smoke, do you gamble, and I have heard more students do it over the last few years, but I wonder if that's a QMUL thing because I've kind of been dotting in and out of stuff. Normalizing the asking. If somebody expresses financial difficulties, ask them. Normal. So in terms of normalizing the asking, not in a stigmatizing way, but so I ask everybody this. Yeah. There's something about recognizing if somebody discloses to you directly or indirectly the absolute bravery that's taken. And one of the reasons that lots of people that are struggling with harms don't come to their GPs is because they've had negative experiences in the past. So I heard a lot of that when I was doing that. So again, just recognizing that, thank you for telling me. And also that risk assessment of if somebody is coming at this point, that you do need to ask things can be so bad that you want to hurt yourself or you harm yourself, and have you thought about that? Just again, as you would ask in terms of if somebody was openly disclosing a mental health issue, you would do that as part of your safety. So yeah, I think those are the sort of the main things. The normalizing the asking, if somebody says and the non-judgmental, the sort of like this, this is not your fault. This is a terrible terrible industry. These are addictive products. This is a predatory industry. It is not your fault, and everything you're being given this idea that everybody else is doing this okay, and it's you've got to change your behavior. So those are probably the things that I would say. The conditions are, I mean, the MLA is another kind of moving target. I've been involved in assessment sort of more in the last couple of years. I'm really pleased to see it there. Conditions at the moment are non-exhaustive, where presentations they've said are sort of static in terms of their presentations, and this gives us a lever in to be able to sort of formalize it. I'm going to go and speak at the Public Health Week in year 3 and have a look at sort of where we can dot it into the other years as well, not just in psychiatry, not sort of just giving it that addiction framework.
Thank you. Yeah, really, really helpful to those little tips. In terms of, we've got some questions coming in now. So we've got Judith has asked us, she was shocked in Australia at the extent of the gambling there in bars, surf clubs, etc. Are they doing anything different in Australia or elsewhere, I guess, in terms of primary care or public health or legislation that you're aware of, Jenny?
Yeah, so they tend to organise things by state. But again, with the population data, so they could turn around and say, right, we're closing all of the places that have the machines over a certain time, or we're closing individual machines down, we're closing sort of certain machines down and measuring it. But again, the data isn't brilliant. So one of them, I always remember that they sort of closed down all the machines, but then the casino in Sydney said in New South Wales over a certain time, but then the casino said, oh, we're different. So they were kind of excluded. So the data, the research isn't good, but they're definitely sort of talking about it more from a population level. There's an alliance that's coming out that talks sort of a lot about it as well. We could learn a lot from them in terms of their sort of population level. Yeah, so the pokies are everywhere. And I think what the main thing is they're talking about it more through a public health and population lens than we are. But yeah, so that's what we can learn in the first instance. We reframe it. We stop talking about this as a leisure activity, and we start talking about it as a public health issue with primary prevention rather than mopping up treatment when people have lost their money or lost their lives.
Yeah, absolutely. I've got some questions myself, but I'm going to hold back because we've got some more. So I've actually got Martin, but I'm going to hold back for a second if that's.
Hi, Martin. Haven't seen you in a long time.
Martin,
yes.
And let me see if I can just unmute. Martin, you should be able to speak now if you unmute yourself.
Martin is somebody that I met in the PhD who's very vocal. Hi, Martin. How are you? We're silent.
Allow mic, and it should be able to unmute. Oh, we're having some difficulties. Maybe we'll come
Martin,
back.
Maybe put it in the chat or something.
Yeah, we'll come back.
Can't do that. Yeah.
So Gordon's got an interesting one talking about Gamblers Anonymous, and does it have the same religious element that AA has that can sometimes might put some
people off?
Some people?
I think they're very variable. I certainly took Alex to quite a few, not just the Gam-Anon one, and then very occasionally they did ones where family members could come when people got pins and badges. I think it's quite variable, and it's anonymous. It's kind of a closed fellowship. Not so much. I mean, alcohol and Alcoholics Anonymous came out of the American, and lots of people were put off by that. Again, I listened to a lot of podcasts from people that had been, and I think the thing was it was available. It was the kind of thing when you hit rock bottom, the thing you have to do is go somewhere now. You have to go somewhere now, and because of the prevalence of Gamblers Anonymous, like I said, there's always one around that you can get to. I think it is very variable, but certainly, I mean, I went to quite a few across East London and didn't see those kind of overt religious overtones. And again, in North East London, one of the reasons I said I wanted to do gambling harms in North East London, and somebody said to me, well, why are you doing that? There's loads of people that don't gamble because they're not the right religion to. That is not the case as well. And in fact, a group of people, if you're from a religious group that does not gamble, it's even more stigmatizing if you do. So I think it's very variable, but certainly haven't seen it. But in terms of my own experiences at Gammon or Gamblers Anonymous and the times that I've been.
You've touched on this a little bit already, but I guess going into it in a bit more detail, anything. So Owen Evans has said, what are some specific and realistic actions you would like the government to take? He was saying he's not confident they're doing / will do enough, and recently went to was spending some time working in Parliament and shocked to be invited to a drinks event co-hosted by the Betting and Gaming Council.
So there's that nexus as well, isn't there? So I can totally see why the Betting and Gaming Council, who represent the gambling industry, are linking up with prostate cancer, because that's your demographic in terms of, or one of your demographics, your most sort of the demographic you immediately think of, that you might have a sort of a common denominator there in terms of the demographic. What would I like them to do? I would like from a local government, because that's where I did my research, I would like local governments to be able to have a statutory, at the moment there's something called the statutory aim to permit. You have to prove that to stop a new premises opening, you have to prove that that premises is going to cause harm. So actually you have to be able to look into the future. So if somebody's opening, like trying to block one in Birmingham, you can't say, oh, but look what happened when we opened one in Sheffield. It will go, yeah, but that's not comparable, is it? So we have a law where people have to look into the, you have to kind of say something's going to happen that doesn't exist yet. I mean, it's completely bonkers. So I think getting rid of the statutory aim to permit for the statutory aim to permit for premises for local, and I think something about, although I don't know how it would happen, some kind of better conflicts of interest list. Politicians should not be getting free tickets to the Euros or any sort of sports events from that nexus has to be completely blown apart. Probably not just in gambling, but in like fast food and in alcohol and in all of those industries. And this is the commercial determinants of health. So this is a relatively new area of public health, but we talk about and Chris Van Tulloken does a lot in this kind of the fast food space for commercial determinants of health, but it's the same kind of thing. So something along those lines, good practice along those lines. And we could learn a lot from Australia there as well. They have some harmful product policies that are done in their at local government level. So those would be my two things, I think.
I am trying to allow mics from Martin and now Liz as well, but
that's okay. They're from.
Hello.
Yeah. Aha.
We can hear Martin you. Will need to unmute from his end.
Yes, that's what I was hoping. Try unmuting Martin or Liz.
Right, can you hear me?
Yes, we can.
Oh, great. I'm sitting here pulling my hair out because I couldn't unmute and I couldn't ask a question in chat. Just a few quick points that your listeners might find useful. For those who don't know me, I'm an affected other, along with Liz. Lost a son to suicide. What you might need to bear in mind if you're meeting patients is that gambling does rewire the brain, and they will not be thinking or answering rationally. I think the best illustration of that I could direct you to is if you go on YouTube and Google for, I think it's Professor Knott and Tony Franklin, you'll see Tony in a brain scan playing slots on his phone and see different parts of his brain reacting. And that's the most graphic illustration that explains why gamblers don't think rationally. And I think as you're talking to them face to face, you can't see that. And that's a good thing to bear in mind. The second is the scale of the harm. The Gambling Survey Great Britain is now quoting 2.7% of population That's 1.4 million people being severely harmed, or 4.5%, I think it is, of gamblers who are being severely harmed. And beyond that 1.4 million, there's probably another 5 million who are harmed to a lesser degree. And beyond them, there are millions who are affected by their harm. So this clearly isn't a leisure industry in my lens. It's a harmful industry, but there is not yet the political will for politicians to wake up to that, because that then flows on to some policy arrangements. I think without hogging everything up, the other thing I'd flag is how successful will treatment be? I ask that question to anybody I bump into, and my sense over time is that with most, and I'm teaching to the people who know better than I probably, that only 60 to 70% of treatment for addictions will end up as a successful outcome. And I think there's no reason to suppose that gambling would be any better. So the other thing I'd flag is expect to see some people on the rebound, people who've attempted to get over it and who've relapsed and have basically going through the rinse and repeat arrangement. I'll shut up there, but happy to come back and contribute some more if you run out of questions.
Thank you so much, Martin. That was really helpful to hear sort of your insights as well, and so important, highlighting, as you said, it's a chronic problem. It's not something you will have relapses, and being upfront about, the same way we are with other patients with other problems with addictions and things like that. I'm very conscious of the time. We've got loads of questions coming in now. Thank you, Jenny, for responding to Zane. I think if it's okay, in the interest of time, I'm going to make a note of the questions, and we can come back to, we've got your registration email, so we can come back to you and give you some updates from Jenny if she's happy to answer those offline. Thank you, Jenny. So I'm just going to very quickly share a quick slide as I talked about. So basically, we would really welcome and value your feedback from today. This is our first of the series this year. So if you could please have a little look at this QR code, and if you could scan that, we'll be sending it around anyway in our sort of post-seminar email to complete. But yeah, as I said, we're very keen to keep developing this as we go forward. We've got our next speaker. Sorry, I'm just going to change to our next speaker is going to be on Tuesday, the 11th of November. That's with Professor Paul Little, who's going to be talking about antibiotic use and antibiotic stewardship in primary care for respiratory tract infections. Very topical as we go into winter. So again, please just head to our Primary Care Seminar Series website and you can register for that. I'm going to stop sharing if I can somehow work out how to do that. So thank you so much again, Jenny. That was an incredible talk. I can see there's still questions coming in. Liz as well, I can see you're there. So if you, we'll make sure we reach out if you're not able to, for whatever reason, publish in the chat, and make sure that we can get a response to you if Jenny's happy with that. And with that, I will leave it there. Thank you very much and good night.